Hi, welcome to the NEET PG Core Revision series in Pharmacology, where I will be discussing the important topics for the upcoming NEET PG examination. Today I'm going to talk about anti-TB and anti-leprosy drugs. So this is the structure or the image showing the target sites of various anti-tubercular drugs, the first line drugs. So here we have isoniazid, which are targeting the mycolic acid synthesis of the cell wall. Then we have ethambutol, which inhibits the arabinogalactin synthesis again in the cell wall, ultimately inhibiting the mycolic acid only. Then we have rifampicin and the drugs like rifabutin, which is targeting the RNA polymerase, and then we have pyrazinamide, which also targets the cell membrane. We'll be discussing how. Now, the important question, apart from the mechanism of action of these drugs, is they often ask you, what is the mechanism of resistance? Which genes are responsible for resistance occurring in the mycobacteria? So, the first here we talk about, the first drug here is isoniazid, and the two types of resistances is because of mutation in genes. One is INHA, right? So, this INHA, it gets or it brings about the target resistance. That means the target modification occurs here. So, INH can't bind properly to the target. So, it is target modification. Now, INH or isoniazid is a prodrug which needs to be activated, and the enzyme which activates is called as catalase peroxidase. Now, that catalase peroxidase is encoded by a gene which is called as CATG. CATG gene. So, if there is a modification in this particular gene, then what will happen? There will be decrease in the active form of or decrease in the activation of INH. So, the action will not occur. Number 2 is ethambutol, and in the ethambutol we have EMB gene, and again this leads to alteration in the target, altered target of the drug. Third we have rifampicin, and in this we have RPOB gene, and this is going to alter or cause alteration in the target site of RNA polymerase. So, it will alters RNA polymerase. Then number 4, we have pyrazinamide. So, we have PNCA gene here. Again, this is going to, because again pyrazinamide needs to be activated. So, this decreases the activation. It's easy to associate, INH means isoniazid, CATG you have to remember for isoniazid, EMB you can make out it's for ethambutol, RPO you can make out it's for RNA, that is rifabutin or this rifampicin. Then P stands for pyrazinamide, so it is easier to associate these genes along with the drug. Now let's move on to the comparison table between these first line drugs, very high yield. The first is the mechanism of action. Okay, before I go on to that, I want to state or reiterate the fact that all the first line drugs, these 4 drugs, all of them are bactericidal except for ethambutol, which is bacteriostatic. Remember this. Now let's move on to the mechanism of action. So the first is pyrazinamide. It gets activated and it disrupts the cell membrane. Disrupts the cell membrane. It inhibits fatty acid synthase 1, FAS1, and therefore it will weaken the cell wall. Ethambutol, it inhibits enzyme arabinosyl transferase, transferase, which is going to decrease the synthesis of arabinogalactin, which is also a component in the cell wall. Rifampicin. Now, rifampicin, R for rifampicin, R for RNA polymerase. So, this is going to inhibit RNA polymerase. Isoniazid, it's a prodrug. It needs activation. So, it's activated, important point. It is activated by catalase peroxidase and it inhibits the mycolic acid synthesis. Mycolic acid synthesis. Site of action, you can, except for pyrazinamide, all the others can act both intracellularly as well as extracellularly, except for pyrazinamide, which is intracellular. So, pyrazin, zin means in, you remember, pyra is in, always intracellular, right? Pyrazin in, that is cellular, remember that ways. Action, pyrazinamide, rifampicin, P and R, both, they are responsible for non-replicating bacteria or persisters, while the ethambutol and isoniazid, they act against the rapidly growing organisms of the bacteria. Excretion. Excretion, all of these drugs are excreted or they are metabolized in the liver except for the second, which is ethambutol. So, this is liver metabolism or excreted as such also, liver, except ethambutol, which is renal. So, they are going to be safe in the opposite system failure. For example, liver drugs, the ones which the primary route of elimination is liver. So, they are safe in renal failures. Safe in renal failure. Safe in renal failure. While ethambutol is safe in liver failure. Opposite, right? Adverse effects, again very, very important to know the adverse effects. So, let's do the adverse effects. The first, which is pyrazinamide. First important adverse effect, it is hepatotoxic. Hepatotoxic, and it is one of the most hepatotoxic drugs out of the rest of them. So, it is the most hepatotoxic. It also leads to increase in the uric acid levels. It can cause hyperuricemia. So, therefore, it is not advised to be given in patients of gout, or you have to be very careful there, right? Then it can lead to arthralgias, joint pains. Coming to ethambutol, E for ethambutol, E for eye. So, it has a lot of eye side effects. So, it can cause retrobulbar neuritis and red green color blindness. Rifampicin. Rifampicin, again, one is hepatitis. It causes, you can say, the reddish or staining, reddish orange staining of the various secretions of the body, right? So, it stains the body secretions. So, if you don't tell the patient can get startled because of the, the urine coming orange and red. So, you have to tell the patient, stains the body secretions. So, the contact lens wearers also, they need to be given a precaution that the stains, the lens can get stained because of that, right? So, it stains the lenses. It will stain the contact lenses. So, here rifampicin, I will write more. So, then hepatitis, staining of the secretions, it can lead to cutaneous syndrome, cutaneous syndrome, flu-like syndrome. Remember, we cannot repeat. Once you have to stop giving the drug and you cannot repeat. In case of stop the drug and don't repeat. So why do you need to stop the drug in case of and not repeat? This would be in case of respiratory syndrome and purpura. Okay. Then we have the last drug here is isoniazid. Now isoniazid, remember, very easy trick of its major side effects is, remember, it is INH. So N stands for neuropathy, H stands for hepatotoxicity. So these are two major problems with this drug. So the first one is peripheral neuropathy. Peripheral neuropathy, and this is mostly in case of slow acetylators. You know that INH gets metabolized by acetylation. So we have slow acetylators and fast acetylators, the one who metabolize slowly and faster. So in people who are slow acetylators, their major or their prominent side effect or adverse effect is peripheral neuropathy. And the treatment is that you give vitamin B6, pyridoxine. To prevent this, obviously, whenever we are starting anti-TB therapy, we always give prophylactically pyridoxine 10 milligrams per day. Then the second one is hepatotoxicity. Hepatotoxicity, and this is more common in case of fast acetylators. And the third one, it can cause psychosis. It decreases the levels of GABA. So these are the major adverse effects which is seen with these particular drugs. Now rifampicin, apart from being an anti-TB drug, has other important uses as well. So what are the other uses? It is a very important drug in case of leprosy. It is used for prophylaxis of contacts or prophylaxis of meningococcal meningitis. Then brucella along with doxycycline, Then it can be used in MRSA and in diphtheroids. So in all these conditions, we can use rifampicin. Another important thing to know about rifampicin is it's a very, very potent enzyme inducer. So it's a very, very potent enzyme inducer. So if you give it along with other drugs, there are bound to be various drug interactions. So important, like it can cause failure of oral contraceptive pills. If the lady who is a TB patient and is on rifampicin, and if she is either already taking or starts taking OCPs, there will be failure of contraception because it causes metabolism. So therefore, what is the treatment? That she has to be advised alternative method of contraception. Number 2 is warfarin. With warfarin, it can cause warfarin failure. Treatment, therefore, or what is the alternative? Therefore, use heparin instead. Third is failure of anti-HIV drugs. So what is the remedy or treatment? We use a drug which has less of drug interactions, like we use rifabutin instead. Okay. All right. Moving on to the second line drugs. Very, very important. Quite often asked. What are these important newer second line drugs? So one is bedaquiline. So what is the mechanism of action of this bedaquiline? So bedaquiline, see the name says that it always lies on the bed and it is resting only, right? It has no energy. So what bedaquiline does, it blocks the mycobacterial ATP synthase. So therefore, the bacteria have no energy. They're lying on the bed. So therefore, no energy in the bacteria. Now, bedaquiline is a cidal drug. It has a very, very long half-life. So it has a long half-life of 165 days. So you give it 3 times per week because of this long half-life. Now it is hepatotoxic and it can also prolong QT interval. Because of these reasons, we don't give it beyond 6 months in any regime. The next we have delamanid and pretomanid. Now both these drugs, what they do is they are going to inhibit the mycolic acid synthesis and they produce a reactive species. Okay, so they produce a reactive species. Again, this is also a bactericidal drug and this is 99% they are plasma protein bound drugs. About the adverse effects, delamanid, it causes QT prolongation. Pretomanid with a P causes peripheral neuropathy. Okay, pretomanid with a P has peripheral neuropathy. Delamanid causes QT interval just like bedaquiline. Linezolid, it's an antimicrobial drug which inhibits the protein synthesis. So this is a drug which binds to the 23th fraction of the 50th ribosomes, inhibits the protein synthesis. Very important. Now here it has to be given for a longer period of time. So the adverse effects which we are more worried about here, that is bone marrow suppression or depression, which is reversible. But we also can have peripheral or optic neuropathy, which is irreversible. So these are the important newer second line drugs on which the question is asked. Then we have the other older drugs, other older cidal drugs. What is important to know? In thioacetazone, this we don't use in, not used in immunocompromised patients. Immunocompromised patients. Pass, it can lead to hypothyroidism. Ethionamide also causes hypothyroidism. It is also hepatotoxic and there is cross resistance with INH. So we cannot give, if there is a resistance to INH, we can't give ethionamide. And there is cross resistance with INH. Okay, hypothyroidism, PAS and ethionamide both are associated with. Ethionamide is also paratoxic and has cross resistance with INH. Cycloserine can cause psychosis and suicidal thoughts. Okay. Now, we have grouping of the anti-TB drugs in group A, B and C, and this is actually group when we were designing the longer MDR tuberculosis regimes. So we have to include all the three medicines from group A, at least one or two from group B, and let's say from group A and group B, we are not able to use one or two medications because of some contraindication. Then we add, to supplement those, we add drugs from group C. So in group A, levofloxacin, bedaquiline, linezolid. Group B, clofazimine, cycloserine or trazodone. And in group C, we have the other drugs like ethambutol, delamanid, pyrazinamide, imipenem, meropenem, amikacin, ethionamide, etc. and PAS. Right? So remember, that's why this grouping has been done. So when they say you add group drugs from group 1 especially, so we mean we add these three drugs from group A. So let's see the various treatment regimes, which is important. Now, in case of MDR tuberculosis, multidrug-resistant tuberculosis, what is important to know is that we have now a shorter regimes, which are because of bedaquiline, shorter regimes. So here the intensive phase is of 0 to for 4 months. No, intensive is of 6 months, but for first 0 to 4 months, we are using a total of 7 drugs. Bedaquiline, levofloxacin, clofazimine, pyrazinamide, ethambutol, high dose isoniazid and ethionamide. So what do you mean by high dose isoniazid? We are using 15 milligrams per kg per day. That's a high dose. Then for the next 2 months, what you have to do, you simply remove the last two drugs. So you remove INH and ethionamide, and we have the 5 drugs now. So we have bedaquiline, we have levofloxacin, we have clofazimine, we have pyrazinamide, and we have ethambutol. So these are 5 drugs now. Now I told you bedaquiline cannot be given beyond 6 months. So when we move on to the continuation phase, which is from 7 to 9 months, you just remove bedaquiline from here. So remove bedaquiline and continue with 4 drugs. So this is a shortened regime because of addition of bedaquiline. That's why it has come into picture that because of bedaquiline, the regime could be shortened for multidrug-resistant tuberculosis. Now for pre-drug, pre-XDR or pre-extensive drug-resistant tuberculosis. So what is pre-extensive drug-resistant tuberculosis? If there is MDR plus in addition there is resistance to any of the fluoroquine. So what to be done here is we have a B-PAL regime. So we have a B-PAL regime and this is for 6 to 9 months. Again, it's all oral. So here we have bedaquiline, we have pretomanid, and we have linezolid. Right? Pretomanid, linezolid, and bedaquiline. Now there is also another regime. So if those MDR patients, the ones which could not be taken up or who could not be given the short PPAL, this regime, so exclusion to this MDR. So either we have XDR or exclusion cases of MDR who could be given the prior this regime. They now need to be given drugs for about 18 to 20 months. So here we have the long regime, the longer oral regime. So here I was talking about that we need to include groups from A, B and C. So here what you do is for 0 to 6 months, we have the regime of around 5 drugs. 5 drugs. So 3 from group A plus 2 from group B. Then 7 to 18 months. So for 7 to, we cannot use bedaquiline. So for 7 to 18 months, we use 4 drugs. We use levofloxacin. We use linezolid. We use clofazimine, and we use cycloserine. So apart from bedaquiline, we use the other drugs. Now, in case let's say some patient has or has contraindication to any one or two drugs, then we take drugs from group C. Otherwise, we mainly rely on group A and B. So this is the importance of knowing about group A, group B, and group C drugs. All right. Now let's see a question which was asked in one of the previous year's paper. Which of the following is an inclusion criteria for the shorter bedaquiline regime in the treatment of tuberculosis? Number 1, extrapulmonary tuberculosis like tubercular meningitis, rifampicin resistance with both CATG and INH mutation, rifampicin sensitive tuberculosis, or rifampicin resistant but fluoroquine sensitive tuberculosis. So what should be the exclusion criteria for this? So let's see the exclusion criteria and the inclusion criteria for short bedaquiline regimes. So the indications for like the inclusion criteria is number 1, it should be a rifampicin resistant or an MDR-TB. Number 2, it should be resistant to sensitive to the fluoroquine. It should be sensitive to the fluoroquinolones. Then it should only be pulmonary tuberculosis. Then we have the age of the patient should be greater than equal to 5 years. Then it should be, the patient should be clinically stable. Then no prior use of any second line drug should be there. So this is all the inclusion criteria. What is the exclusion criteria? You cannot give this short bedaquiline regime if there is resistance to fluoroquinolones. If it is an extrapulmonary tuberculosis, so there is extrapulmonary tuberculosis. For example, it is TB meningitis, right? Or TB is in the bone. Then you cannot give this. Then the third, if there is QT prolongation, because bedaquiline also causes QT prolongation, and if patient already has this QT prolongation, you can't give this. So the question for us here was, which of the then is an inclusion criteria? So extrapulmonary, this becomes an exclusion criteria, not an inclusion. Rifampicin resistant with CATG and INH. So CATG and INH, this is not rifampicin, this is INH resistance. Rifampicin sensitive tuberculosis. No, we need a rifampicin resistant TB. And the last one is rifampicin resistant but fluoroquinolone sensitive. Yes, we need a TB which is still sensitive to fluoroquinolone. So this is the correct answer. All right. Next we have in special situations like let's say there is tuberculosis along with HIV. Now what to do? So if there is a patient on HIV and of HIV who develops tuberculosis, what should you treat first? So first you should treat the tuberculosis. So start anti-TB therapy first. And after 2 weeks you give antiretroviral therapy. This is so because if you give antiretroviral therapy beforehand, because the immune system of the patient is going to improve, they are going to target the mycobacteria. There's going to be an immune reaction, and this is called as, there is going to be risk of IRIS, which is called as immune reconstitution, inflammatory syndrome. So because of this problem, the immune system's action against the mycobacteria, so therefore you need to treat the TB first and then you follow up with ART. Also, another thing that you should know in this, you replace, to take care of the drug interactions, replace rifampicin with rifabutin. What about pregnancy? You can give all these drugs, so just avoid giving aminoglycosides. Right? Only aminoglycosides cannot be. They are contraindicated in case of pregnancy. Alright. Now, moving on to the next disease, which is leprosy. So, what are the important drugs for leprosy? Now, leprosy we treat if it is multibacillary or it is paucibacillary, depending. So, how can we make out if it's multibacillary or paucibacillary? By looking at the lesions and the other features. So, if there are 6 or more lesions, it is multibacillary and more than one nerve involvement is there. While in paucibacillary, the lesions are 1 to 5, skin smear is negative and there may be no nerve involved or only one involved. Now, the treatment protocol is the same for both of them. The only difference is in the duration of the treatment. So now, the duration of multibacillary, obviously it is longer, and for paucibacillary it is shorter, that is about 6 months. Otherwise, it is the same. The drugs are same. The way in which it is given is also the same. Now, let's see that. So in children also, in 10 to 14 years, the dosage is different. So we'll do that as well. So rifampicin, we use 3 drugs: rifampicin, dapsone, clofazimine. Now, out of this, rifampicin is the only sidal drug. The rest 2 are static drugs, right? And clofazimine is also an anti-inflammatory. So, you give rifampicin 600 milligrams once a month. Here also 600 milligrams once a month. Both. So, obviously, if it is just once a month, it can be supervised. So, these are both supervised. Dapsone has to be taken 100 milligrams daily. 100 milligrams daily. So, obviously, every day nobody can supervise. So, this is unsupervised. Coming to clofazimine. So, how to remember for clofazimine? Now, do half of 100, it is 50. So, the patient has to take 50 milligrams daily. Daily dose of dapsone is 100. So, half it is 50 milligrams daily for about 29 days. 29 days. Same here, 50 milligrams daily for 29 days. Unsupervised, daily is never supervised, plus or and once he has to take half of 600, that is 300. So 300 milligrams once on 30th day, you can say. So 300 milligrams once on 30th day. So obviously once, whatever is once in a month, that can be supervised. So clofazimine, easy to remember. Half of 100, the half of the daily dose is now 50, which is to be given daily, and the one dose which has to be given on one day should be the half of the dose that was given previously for one day. So 600 half is half, 300. So here it is given 300, here it is 50. Now let's go to the children, dosage in children, how to remember that. So first we'll go and see for dapsone. So dapsone, the dose is half here, right? So here we have 50 milligrams, right? Half of the dose. Now, for clofazimine, it is again same, 50 milligrams on alternate days. That's the difference, on alternate days. plus add 100 to 50, it becomes 150. 150 milligrams. So, one day has to have 150 milligrams. Now, what you do? You do add here. This is 150 and here you have, how you remembered it, 100 plus 50 is 150. Now, go to the rifampicin now. So, rifampicin dose is now how much? 450. Rifampicin dose is now 450. Okay. So, this is the difference in the children's dose. Here, first we are doing this 50 and then we are doing 50 plus 150. So, half of dapsone, 100 was the adult dose, 50 is the half the dose, and we come to clofazimine to give 50 but on alternate days, and you do half of 300. You can do, that is 150, or add 100 to 50, it's 150, any way which you want to remember. So, this becomes your 150 and you can add here 450 of the rifampicin. So, this is the only difference in the dosing of children versus the adults. Now, other drugs which are used in leprosy, which we already done, apart from dapsone, clofazimine and rifampicin, we have ethambutol also, which is also an anti-TB drug. And then we have certain antibiotics. We have fluoroquinolones, we have macrolides, and we have minocycline. So, fluoroquinolone, macrolides are both cidal drugs here, and then we have minocycline. Okay. Now, dapsone, important thing, inhibits the fatty acid, folic acid synthesis here. So, dapsone inhibits the folic acid synthesis, very important. And the adverse effect, important, is it causes hemolysis in G6PD deficient patient. It can cause nausea, vomiting, and sulfone syndrome. Other uses, it is also used in chloroquine resistant falciparum malaria and pneumocystis jirovecii. Other uses of dapsone. Then let's do some important points here. The most potent or the most effective drug for leprosy is rifampicin. Right? The main adverse effect of clofazimine. Now, clofazimine is the dye. What is the main adverse effect of clofazimine? It is reddish black discoloration of the skin and this is called as ichthyosis. It looks like a fish-like skin, right? Ichthyosis. What to do in case of single lesion leprosy? You remember the mnemonic ROM. Give these three drugs that we have: rifampicin, ofloxacin, and minocycline. Lepra reaction, ENL. Do not, in case this occurs, do not stop the multi-drug therapy. So, do not stop the multi-drug therapy. You give steroids here. Give prednisolone first to stop this reaction. If it is still persisting, if still persists, then you give other anti-inflammatories like thalidomide, or you can give clofazimine. Okay, but remember, thalidomide is absolutely contraindicated in case of pregnancy, right? Because it had association with phocomelia. So these are the important points about antitubercular and anti-leprosy drugs.